Good morning and welcome to this morning's webinar. My name is Daryl Moon and I will be your host today. This is the 8th webinar in our series of short 30-minute webinars on the best practices of managing population mental health, brought to you by Going on Offense and sponsored by Resilience Pro. Recordings of each of our previous webinars are available on the goingonoffense.com website. As we know, the pandemic has heightened the need to address mental health. The uncertainty that we all face is having devastating effects on emotional well-being across the country. We've had the privilege of managing population mental health for over 20 years in a very creative new strategy. Instead of a more restrictive managed mental health philosophy that most work with, we've attempted to prove that by being abundant and by really engaging early intervention and getting people into care quickly, you can actually provide wonderful benefits, get people in quickly to the providers that they need, not have to focus so much on the benefit design, and actually make money by providing more care and more early care and getting people again into prevention and preventing serious mental illness in the first place. Because of the pandemic, we decided it would be a good idea to share many of the best practices that we've learned through these webinars. And so today we're addressing a topic, and let me just share with you before I introduce today's topic, some of the topics that we've already covered in this series. So far, we've addressed integrating mental and physical health, overcoming the stigma barrier, technology that monitors the emotional well-being of populations so that true preventive maintenance programs can be implemented to maintain optimal mental health. How to attract and retain top talent through supporting emotional well-being, filling the holes left by many EAP programs, proactive emotional health and measurement-based care. Last week, we focused on the role of technology and mental health apps. Today, our topic is ensuring prompt access to the right mental health provider. Of all the topics we have covered during this series, this topic perhaps is one of the most important. Second to only early intervention, connecting patients with the right provider in a timely basis is critical in managing population mental health. The common strategy of giving patients a list of providers to call is one of the biggest reasons our current mental health system is so broken. The provider lists are generally not up to date. Too often providers on the list are either not taking new patients or have a wait time of 2 to 3 months. If someone is in need of seeing a mental health professional, having to wait 2 to 3 months is the worst thing for them. The solution that we have found to be most successful is the use of specialized mental health case managers who know the provider network and coordinate the connection between the patient and the provider and make sure that the patient gets to appointments and is seen promptly by those mental health professionals that specialize in the need of that specific patient. I'm honored to have with me my guest today, my good friend Tina Halliday, licensed clinician and manager of the University Neuropsychiatric Institute Behavioral Health Network. Tina's been managing this process for our solution for close to 20 years now. She and her team do an amazing job of ensuring patients who need more services than what the preventive level of care can offer, the EAP, get prompt access to a licensed clinician who specializes in the specific need of that patient. I'd like to give Tina now a chance to introduce herself. Tina?
Hi, thank you for the invitation, Daryl. Daryl and I have been together for many years now, working on building and continuing to develop our product with Uni Behavioral Health Network. I'm a clinical social worker. I've been in practice for 30 plus, I'm stopped counting now, years, and have been with the University of Utah for 20 years and manage my team of 5 of us all together with 2 clinicians who are my care coordinators that facilitate the process that Daryl has just introduced to you. Pleasure to be with you.
Thanks, Tina. First of all, why don't you describe the handoff between the EAP provider and your team and what role the EAP or preventive level of care provider plays in helping you identify the best provider for the patient?
Sure. So this is meant to be a continuum of care to guide people. Unless someone's familiar with the behavioral health world, it becomes a very difficult world to navigate. And we're asking people to navigate that at their most volatile time in their life. So our goal is to kind of handhold and get folks to the right level and type of care, the right specialists and treatment. So the Employee Assistance Program is available for folks for short-term an assessment, and for anything that they can't manage in their short-term kind of an approach, they will refer on to my team. My team then gets a clinical snapshot, enough to help us guide into making direction for folks and getting them connected to the right type of care, level of care, right specialist, and also removing the barriers of geo access, time of day, when appointments are available, and with someone who actually has the specialty and does have appointments open for them. So we'll match up the right kind of provider and talk to that member and coordinate their care, and then continue to be available if for some reason that doesn't work for them. It's great to have a name and a good idea, but if something doesn't work, then we're going to lose that person to the slipping through the cracks and not be in care. So we're there as a constant to help them and be a connection for them going forward as well, to either add more care or continue to provide the right resources that they might need.
Wonderful. So talk a little bit about how you manage the network and why providers like working with the way you do care, and how are you able to stay up on who's seeing new patients?
So we, from the very beginning, felt very passionate about finding the right providers that we believe are trained well, have good experience, that we believe in, that we'd refer our own child to. And so we've taken great lengths to go out and meet providers, to get a feel for their practice, to learn about them, to build rapport with them and continue to work with them. So we're always kind of building that rapport as we work with them going forward, and talking to them, interacting with them, specifically around cases and referrals. We're continually adding, because I think people have learned about us and they're asking to be on our network. I believe over all these years, we've been a good partner to work with. And that's exactly our approach we've taken, is these are our partners. These aren't people that we are there to scrutinize and limit care with. These are folks that we trust with our members. And we see them as a partnership, and I think they appreciate being treated as a professional. There's not a lot of hurdles, unuseful hurdles with these folks, because again, we've built this relationship and this level of trust with them. So I think our system has been very user-friendly to work with all around, whether it's a referral, whether it's looking together at the nuances and the uniquenesses and being creative about how to support our members through their difficult times. Or if it's claims or administrative issues, we're there to support them and help them and navigate for them also all of these parts and pieces, so that their focus and their time can be spent with our members in a clinical realm.
One of the issues that often comes up in mental health is the fact that there's not a blood test to determine if the person has a particular disease. It's very much an assessment. And so sometimes managed care companies are very scrutinizing of whether therapists are, expanding the notes or kind of building in justification for why the patient needs care. And in our model, people are seen through a preventive level of care. And those low-hanging fruit, situational depressions, things that don't really require a long-term serious clinical intervention, are handled by the preventive level of care. So right off the bat, we've taken that part out of the system. We don't have to scrutinize whether the therapist is expanding the notes or trying to justify unnecessary care. We know that these patients need a provider that's a more serious intervention to take care of the patient. Talk a little bit about how therapists like that fact that some of that low-hanging fruit has already been taken out of the system and handled by the preventive level of care.
Again, I think the beauty of our product is everything is guided from a clinical decision-making process. So we're trying to get people to the right type of care with easy access early on to prevent longer term care. And so I think the beauty of this is knowing, because of that early care that you're talking about through the EAP part of our benefit design, helps us to guide very carefully the right kind of referrals to our providers. And I think our providers are appreciative of that. That when we send a referral, we're saying, here's Sally Joe, and this is the clinical presentation, and we believe this does fit for you. Are you comfortable taking this client? So it's, again, they're having a client come in not totally blind to what kind of a case they're accepting into their caseload with their timing and their resource or their limited amount of resource at any given point in time. And again, it's very individualized, Daryl, that as we have that initial assessment, this person's going to need a longer length of stay and maybe other wraparound services versus, you know, here's Sally Joe, we're going to send her your way. And a
Right.
clinician is blind to what kind of client am I taking? And I think clinicians are very careful about who they want to take, because they want to make sure that they're trained appropriately for what is coming in their door. Again, it's better level of care as well for the client, because then they're not starting and stopping and starting and stopping. Anything we can do to alleviate losing that person from the point of access to continuing care is significant for better health and better care and quality of care for our members.
Well, and maybe expand a little bit about how critical it is for the patient's recovery and treatment and positive outcomes that they can get connected to the right provider, and one that they can actually work with and feel comfortable with and build that trusting rapport with.
Yeah, exactly. Again, when they have the right type of provider and they have a certain degree of energy or motivation, we want to jump on that as soon as possible and make sure they're connected and connected to the right person too. That's part of us being very aware of our network and who our providers are, to make those right matchups with our member. So again, we have the best opportunity to make that connection, because rapport is the consistent across research over all these years. It's a significant piece of people engaging in treatment and gaining progress and being able to have an ongoing provider, particularly for folks who are dealing with more persistent, severe mental illness.
What do you hear from the patients about the fact that they have a case manager like yourself or your team working with them through whatever the struggles and challenges might be? What do you hear from the patients about the fact that there's that relationship between you and them, and that they know you're there to help them get to the right provider?
You know, we often get comments from patients that they're just so grateful to have guidance and help. You know, it's hard to navigate a world you don't know about, and then you open up a book of providers, or you go online to your insurance, and you know, how do you pick and who do you go to? And so having someone, a real person, walk them through that and help them understand their benefit, understand limits of benefits, because that's the real world that we live in, understand how we can be of a help to them, and work along with the member also to guide them through the process of who our providers are and educate them about that provider and get them connected to those resources. It saves them time too, Daryl. I mean, think of our worlds and how busy they are. And then think of a time in your life when you're vulnerable and volatile. You don't have extra energy to extend of researching and, you know, pounding the pavement to find the right person in an area you don't even understand because you've never had a mental health issue before. So their appreciation often comes with, thank you so much for helping me get through this process and find the provider that's worked well for me.
Talk a little bit about what you look for when you're increasing the network, looking for new providers. What are some of the things that, I know you've visited their offices many times just to kind of see what the environment's like. Talk a little bit about what you look for when you're enhancing or increasing the provider network.
We're always kind of have an eye on our access. Providers are very busy. As you mentioned, as you introduced the topic today and the topics you've talked about, our clinicians are full often and actively seeing people. So the good news is people are accessing care. our goal always is to have access. So whether that's a geo access, whether that's specialty sometimes driven, for certain populations that we see more of, a certain diagnosis or disorder, we want to make sure we have enough specialists and in the right geographical locations to meet our members' needs. So those are things that continue our progress of adding to and updating our providers. You know, some of our providers are retired, so we're not wanting to have holes or leave holes in our resource and our range of resource. So those are always things we're looking for. Our panel's been closed for years. That's another thing, is we don't want to just generally just add a bunch of people if we don't need those resources. I think that's a benefit to our providers, is having them do a credentialing process for no need at all or no referrals. So we've managed it from both perspectives of having the right amount of resource and not have excess. So we often have people approach us and ask us to be on panel, and we're always looking at those folks. Again, we want to keep an eye on the community and what resources are available, and our constant process of building and maintaining a provider network.
Talk a little bit about when we bring on a new client, and let's say there are patients within that population that are already seeing a provider and have a good relationship with that provider and are making progress. Talk a little bit about the transition that we have successfully used over the years at allowing some of those patients to continue seeing those providers and to finish up that level of care, and how important that is to overall outcomes.
And I thank you for bringing that up, Daryl. This is, I think, where the uniqueness comes with UniBHN, is we're pretty passionate about treating the individual. And we don't draw a rigid, hard line of, well, now you're part of our network, so you can't see that person anymore. Certainly as a clinician myself, I've been in those position of having someone come in to me that didn't want to and had to interrupt treatment, or having to discontinue treatment because I wasn't a network provider. So our goal, again, is look at the individual, look at the clinical need, where they are in treatment, and what they will benefit most from. So if they have a continuity of care issue, we're certainly going to be working and put our effort out to work with that provider so that member can continue and maybe even complete their treatment, rather than uprooting them in the middle of treatment, or even if they're toward the end of treatment. Why start over again? So it's methodically, very carefully evaluated in terms of how to manage those cases. And in many circumstances, we've just established a relationship with the provider and been able to support and continue treatment for that member.
Nice, nice. Talk a little bit about where you see the greatest shortages. You know, often when you talk about mental health and mental health provider access, there are some shortages, and some specialties have more shortage than others. Where, when it comes to therapists or doctors or MDs or psychiatrists or specialists within various areas, where do you see the greatest shortages often?
I would say by and large, it is in the prescriber field. Mm-hmm. So our psychiatrists, our advanced practice registered nurses are very, very full practices. I've seen this in Utah, but I've also seen it across the country. Not enough of those folks available. So even that community, I think, is thinking outside the box of what other resources can we create? What other flows can we create? Even to the point of creating some relationship with primary care doctors to be supported by psychiatric consults to have a continuum of care for folks who can step down into a primary care physician practice after they're stable on medications. So by and large, definitely are prescribers. There's a definite shortage.
What are some of the ways that we go about when there is a shortage and we need access to those providers? What are some of the strategies that we've used to engage them in working with us so we can get prompt access?
Again, I think our relationship, number one, we have recently, in the last few years, actually hired our own psychiatrist. So this is our specialist who works with our members. That's another unique piece. We've created a psychiatric consult service. So we're working with primary care doctors and supporting them to be able to see folks that would be appropriate for a primary care's practice. Not all people are, but it frees up some space for those who really need a specialist and in terms of a psychiatrist to follow them with their psychiatric care.
Nice. So one of the hallmarks of our strategy is, again, to shift the need for care upstream into preventative levels of care. Mm-hmm. If we can get more people in early, there are fewer people who need the treatment. Talk just in general as to how that has been a hallmark of our our ability to effectively manage populations by getting people into that preventive level of care. Thus, there are fewer people that need the treatment.
Yeah, I mean, the earlier intervention, and I don't know that that's a mystery to anyone, is the most beneficial place to start. And I think stigma is at least lightening up to some extent around mental illness. I think being visible in an employer group and population and the employer knowing and utilizing that resource for their folks is really beneficial to that early intervention and making that a user-friendly process. So I think all of that availability makes a difference. And again, with care coordination, you're helping people, guide them through. You lose a lot of people in the beginning because it's just a hassle. You know, and if I call one provider, maybe I have enough energy to call two, but after that, I'm done. I'm not going to keep calling and trying to find people. I've had indirect situations just for colleagues or other folks in the community reach out to me to say, you know, I can't find a provider. And I'm like, gosh, I wish you had a UniBHN for your employer group. So I've, you know, certainly helped them from a personal level too, but I've seen that frustration from people of not being able to get into care, and people are going to give up. And then you lose that opportunity to do that preventive early work. And often they're going to end up being in a much worse situation and require hospitalization, higher levels of care.
Well, and if you look at the statistics, people wait on average 10 years after mental health symptoms appear before they seek help. So there's that whole waiting period. And then like 57% of people never get help, never do reach out for help. So talk a little bit about what happens when people fall through the cracks or don't reach out for help or, you know, don't ever get the help. What are some of the other medical conditions that can result, or more serious conditions that can result by not getting early intervention?
I mean, when you look at the human being, we're a very intricate, developed creature, right? We have our physical, emotional, mental, spiritual pieces and parts. And I think anytime one of those is impacted, how do you not have impacts in other parts of your being and your literal makeup, let alone the spillover into your family, your community, your employer? I mean, that's why the employer likes to have a benefit like this, because you can get people the support and help they need and maintain the functioning ability of your good employees. Or just, you know, if you've got a family member that's struggling, that impacts your well-being and your focus as an employee, let alone the healthcare costs that are significant related to undiagnosed or untreated mental health issues, from cardiac issues to just general wellness and well-being. It's significant impact on human beings in so many areas of our community, our well-being, our literal body and mind.
We've mentioned this on some of the previous webinars, but again, good research has shown that of all the risk factors, poor nutrition, poor exercise, you know, excessive alcohol use, tobacco use, they all pale in comparison to depression and uncontrolled stress at increasing overall medical costs. Of all the risk factors we need to address and address early, it's those mental health symptoms and those mental health risk factors that have such a significant impact on so many areas of health and health well-being. So Tina, let me just ask.
I was going to say we're also seeing a significant trend of increasing anxiety amongst our youth and suicide.
Mm-hmm. Tina, do you have anything you'd like to share in conclusion? We've covered a lot of these topics about accessing the right provider promptly. Anything we've missed that you want to just kind of conclude with?
I think we've had a pretty good overview. This is a really exciting product. I think we've seen savings in the medical side of benefits. We've seen gratitude from our members. We've seen a lot of utilization and folks getting into, again, the right kind of care. And you were talking about higher levels of care earlier. Just to come back to that topic, is as we've tracked our statistics, certainly we've seen the vast majority of our membership working with outpatient providers, which is our goal. Saves cost, saves, the employer, the cost of losing employees because they can't go to work because they're in a hospital, or being stressed out because their loved one is. I think tracking this product over all these years, it's been so successful on so many different levels. It's been very exciting to be a part of this.
Thank you. Yeah, it's nice to be able to prove that you don't have to raise rates every year to get profits. You can get profits by just focusing on keeping people healthy in the first place.
Yeah.
And of course, that's a great alignment with both the buyer as well as the provider, and the whole system works better when you can do that. So Tina, thank you so much for today's webinar. I'll conclude now, but thank you for your contribution and for the discussion. I do want to mention to everyone that's listening that next week's webinar in this series of best practices of managing population health will be on mental health best practices for youth. With that, we'll sign off. Again, thanks, Tina.
You bet. Thanks, you guys. Thanks for the opportunity to be with you.
Wish everybody a wonderful day. Take care.